Good morning, everyone. I just would like to start by thanking the police chiefs that were here, their colleagues in the audience. The work they do is so critical, so important, so difficult. They do it so well. And please join me in thanking our police for the law enforcement and the safe communities they create. I also want to thank all of you for taking time out of busy schedules to be here with us, to join in this conversation, to share where we are, to put a marker down in 2017 on what we've done and what we need to do. And I'm looking forward to the next day and a half. I am also, as a community psychiatrist, so grateful that you have made behavioral health a focus of our conversations going forward. It came out in our last session. I'm sure it will come out in all of the sessions that we are a part of, that we understand that behavioral disorders are brain diseases. They are ubiquitous in our society. All of us know someone, oftentimes a family member, that has one or more of these conditions. I hope many of us are aware of the robust science that, when appropriately applied, can reduce the disability associated with mental illnesses and substance use disorders. Almost 10 million of us adults this year will meet criteria for a serious mental illness. It's about 4% of our population. Almost 12 million of us will abuse opioids this year, representing about 5% of our population. And unfortunately, it is often more readily available access to a Sally Port than access to a clinic door. And that's why we're here. The numbers I cited were in general population, but in our correctional populations, behavioral health disorders prevalence are staggering. 17% of people booked into our county jails, the front door to our system, meet criteria for a serious mental illness. That's 14.5% of the men, 31% of the women. And you all that run facilities know, well, that's small compared to what I see, and yet we understand that that's just at booking. And things don't go well when you have a behavioral health disorder in many settings, and that number gets concentrated and increases the deeper we move into the criminal justice setting. 65% plus meet criteria for substance use disorders. The opioid epidemic is making headlines. I don't want us to forget alcoholism as a significant contributor to crime within our society and problems with public safety in our community. These individuals are disproportionately people of color, important to understand in designing effective responses and being culturally competent in our services, programs, and policies. And while predominantly male, females are the fastest growing component of our criminal justice system. And all of these individuals, both men and women, experience high rates of trauma from early childhood throughout and have a whole host of comorbid medical conditions. Regardless of the pathway to the criminal justice system, when the individual has one or more behavioral health disorders, the pathways out are not readily available, and they often get stuck. They experience longer stays, both in pretrial and sentence status, controlled for charge and risk than those individuals without behavioral disorders. They have limited access to effective treatments, both inside and outside of our institutions. And they're often caught in this revolving door spinning way too fast of arrest, release, arrest, release, arrest, and release. The story we heard from law enforcement in the panel that just preceded this could also be told by sheriffs, judges, wardens, community correction officers. Behavioral health needs are overwhelming our criminal justice systems. And while incarceration is essential to preserve public safety, and for those who pose a public safety risk, they need to be there. For those that don't pose a public safety risk, we need alternatives to detention and incarceration. For those finishing their jail or prison stays, coming back into our community, effective treatment and supervision is needed to mitigate the likelihood of their return. No one system can be expected to diagnose, assess, treat, remedy the unacceptable status quo. It is neither a state or a local problem, and our panel reflects the continuum from the front door through release in our prisons. It is not just a behavioral or a criminal justice problem, as our Secretary Wetzel conveyed it's a and both problem. It is the case that over the last 15 years, advances in correctional practice and behavioral health treatment have been remarkable, with innovative programs and evidence-based services that have been provided and implemented in your communities and all of our states, specialized police-based responses, mental health, drug courts, cognitive behavioral therapies for criminogenic risk, reentry task forces, a number of programs. And yet we sit here today with the prevalence of individuals with behavioral disorders in our criminal justice system as high or higher than it has ever been. Why? And what can be done to change this narrative? The goals can be simply stated. First, we need to do a better job screening, assessing, and identifying behavioral health needs in our correctional populations. This is both a constitutional requirement and also a public health opportunity. Arrest may be the first time that an individual is assessed and learn that they have a condition that is treatable. We need to ensure that they have access to a broad range of comprehensive services, both within and outside our correctional settings. We need to, just having a ticket to the theater doesn't mean you get a good show. We need to make sure that when you get care, that it represents the science that's associated with good outcomes, and that we increase the effectiveness of these services. And lastly, we need to strengthen the requisite collaboration between behavioral health and criminal justice agencies at the state and local level, both horizontal and vertical integration, to achieve the outcomes that we all care and value. This is the focus, and these are the foci of our plenary. This plenary will be followed by breakout sessions where the conversation will go deeper into all of these issues. It is with great pleasure that I'll introduce briefly our panelists today. Starting to my left, Dr. Valerie Arkoosh. She is from Montgomery County, Pennsylvania. She serves as the chair of the Montgomery County Board of Commissioners in Pennsylvania, elected official. She is a practicing obstetric anesthesiologist for over 2 decades and has always put the health and well-being of her community and local families first. She served as chairman of the Department of Anesthesiology at Drexel University College of Medicine. Dr. Arkoosh has a degree in economics from Northwestern University, attended medical school at University of Nebraska College of Medicine, master's degree in public health from Johns Hopkins Bloomberg School of Public Health with a concentration in health policy, and is obviously able to span the boundaries of our criminal justice and behavioral systems. To her left, Mr. Kieran Hurley. Mr. Hurley is the Director of Criminal Justice Services for CareSource, a leading nonprofit public sector managed care company. He was previously the Director of Treatment Services at the Court Clinic Division of Central Clinic in Cincinnati, Ohio. In that role, he ran mental health courts, veterans treatment courts, oversaw diversion-based programs for justice-involved clients in the county court system. He worked as a legal aid attorney in Greater Cincinnati after graduating from the University of Cincinnati Law School. Prior to attending law school, had a career as a social worker in the community mental health system and provided emergency services in homeless shelters, and also participated in the first forensic assertive community treatment team in the state of Ohio, both behavioral health and criminal justice experience. And far left, Director Lynda Zeller, who provides policy leadership for Michigan's behavioral health and developmental disability systems. Previously, Ms. Zeller served as the Health Services Administrator for the Department of Corrections, which included all health, behavioral health, and dental services for the state's correctional system. Ms. Zeller has nearly 30 years of experience in the field of behavioral health, serving seriously mentally ill adults, emotionally disturbed children, people with developmental disabilities, and those with substance use disorders. She received her bachelor's degree from Greenville College, Master of Public Health and Healthcare from Western Michigan University. So with pride, I stand on this podium at this time with these individuals and our effort and opportunity to think about local and state efforts that may actually make a difference, bend the curve, and address the overrepresentation of people with behavioral health disorders in our criminal justice system. So let's begin, and let's learn from one another. Dr. Arkoosh, a sense of what you're struggling with in Montgomery County to one of these crises that we face, and your thoughts on sort of directions that we might take, please.
Well, good morning, everyone. It's a real privilege to be here with all of you today, and I think just the fact that someone from my background was invited to speak with you today is exciting and is really helping us move the ball forward. I also have the wonderful fortune of being from the same state as Secretary Wetzel, so it's wonderful to have a partner like him at our state level, and that has really helped us move the ball forward. Everything that you said, Fred, was very much what we're experiencing, certainly in Montgomery County and across our state. Montgomery County, Pennsylvania is a county of 825,000 people. It is just to the west. It borders the western border of Philadelphia. It is home to some of the wealthiest neighborhoods in the Commonwealth and some of the poorest. And so my work really runs the gamut. Unlike Montgomery County, Maryland, we have 62 municipalities that collectively have 50 municipal police departments, as well as some coverage by the State Patrol. So when I needed to get police to carry naloxone, for instance, it was really a pretty significant undertaking because there is no one chief. We have 50 chiefs. So I'll just leave that to your imagination. But one of the things that I think, to expand upon your comments, that I see as a challenge, and you heard a little bit, I think, in the panel before us, is that there are many people doing this work, but we don't always communicate well with one another. And I think that's where one of our biggest opportunities is. I come at this work from having been a practicing physician for a number of years and also wearing kind of the public health approach or public health hat to this work. And by breaking down silos, really talking to one another, and figuring out how we can use existing resources, because nobody has enough resources, how we can repurpose and redirect existing resources to come together, I think can go a long way to solving some of this problem. I think data is the #1 tool at our disposal. I may be going out on a limb here, but I think that people who work in the correctional field or in criminal justice tend to be pretty action-oriented, looking for results, working in a very quick and fast-paced way. And people who are on the behavioral health side, in general, want to talk it out. They want to sort of take some more time. They want to get to the root of things. And I think sometimes, for many, many decades probably, we've just been talking past one another. But the crisis that we find ourselves in has focused everyone's attention, at least certainly in my state and in my county, to how we can talk with each other and how we can understand the challenges that each other is facing. So I can kind of go into some specifics, I think, later on, but I'll leave you with that as a starting point.
Thank you. I'm going to ask Director Zeller, and I think you're fresh off a summit where you brought counties from around Michigan together, focused on overrepresentation of behavioral disorders. In what you heard from Dr. Arkoosh, are there things that you found similar to your Michigan counties as well, and things that you would like to add?
Yeah, definitely. We did just have a wonderful summit. Director Heidi Washington helped lead that too as well from Department of Corrections, along with Health and Human Services, which is the agency I belong to. So we did hear very similar things. We did hear also that we heard different messages from different aspects of the community. We heard that the police are thrilled, the law enforcement is thrilled about the opportunity for increased training, and they need a place other than the jail or the emergency room from which to choose. Right now that we're great about identifying people, we need crisis centers, we need mobile crisis response, we need opportunities, especially where people have co-occurring addictions and mental health. Law enforcement has great partners, but we're really starting to hear that they need other alternatives. We're hearing from our hospitals that we need inpatient, specialized inpatient closer to home for people with really serious mental illness and co-occurring disorders who also have challenging behaviors. We have a huge crisis in Michigan in access to psychiatric care close to home, and it's not because we don't have enough beds. I actually only have an 85% fill rate in my beds in my community. So what we need is different type of treatment, very targeted, Also, in Michigan, and I expect we're not alone, we have experienced since 2010 a 48% increase in judicial orders for competency evaluations. 48%, increasingly for misdemeanors. I think that's a statement about the frustration and lack of tools at the local level and the need for us to really get busy in this conversation to try to identify global strategies.
Great, thank you. Back to you, Dr. Arkoosh. Here we have a state leader here that's trying to be supportive and facilitate the action that occurs at the local level. Why does this continue to be so difficult to address? What are some of the most pressing challenges, and what would you ask of a state leader at this point in time?
Well, I think number one, data is particularly important, as I mentioned earlier. Our county has signed on with the Stepping Up initiative, and we've been able to use the data that we're generating in some very tangible and very effective ways. So I'll give you one quick example. Our probation officers often complained mightily about the fact that they have so many people who end up back incarcerated, as we've heard earlier today. And they finally shared that data with folks from our behavioral health and drug and alcohol departments at the county level. And it was very clear to those folks for the first time, in a way that they hadn't appreciated before, how many of those violations of parole were because of either a mental health issue or a drug and alcohol issue. So the data became the Rosetta Stone, I like to think of it, and helped the criminal justice side and our probation side actually have meaningful conversations with staff in other departments. It broke down some silos for the first time, and we now have people from our behavioral health department and our drug and alcohol department co-located in our probation office at least 8 hours a week. I think it's actually going to grow to help work with the probation officers and individual probation, those on probation, to make sure that they don't recidivate for some of these kinds of reasons. So that's one tangible example. The other thing that we've done with great effort and to great effect is using the sequential intercept mapping. And we have actually now done this multiple times. And that looks at opportunities to intervene in 5 separate areas. I'm sure most of you are probably pretty familiar with this. We have, again, used that mapping to develop very robust mobile crisis intervention unit. So rather than, as we heard earlier today, having social workers in our police departments, which would be virtually impossible with 50 of them, we have a mobile crisis intervention team that covers the entire county. It's we actually contract with them to provide that service. They've become incredibly effective. And those families that the police officers were going back to 2, 3, and 4 times, they're now getting handed off to the mobile crisis intervention folks, who then have the ability to help those individuals get transitioned and connected to services. So we're trying to take some of the work that the police were being faced with in getting in the middle of these behavioral health issues that they really don't have the training to do anything other than beyond de-escalating a situation, and get robust services that they can connect those individuals to. We now have a situation in our 911 call center that does actually cover the whole county, where our telecommunicators are sufficiently trained that they can listen to a call, and they not only are deploying a police officer, in many cases they're simultaneously deploying our mobile crisis unit. So those are the types of things that data can help incentivize, and that's the other piece for our state folks, is making sure that these funding streams are flexible enough that we can do this kind of integrated work. If funding streams are too narrowly defined, then we don't have the resources to actually make these things real.
Great. Oh, that's a great. Excuse me, Kieran, I'm going to go back to Director Zeller here again. Here we're familiar with the sequential intercept mapping process, looking at from first contact with law enforcement through release at the county level back into their communities. What can the state do to support that process? And I know many of the counties in Michigan are looking to you to provide some guidance and leadership. What is the role of the state in supporting these efforts that we're hearing about?
So, great question, and as you know, you were with us last week when we had our summit, And so I think one of the greatest responsibilities for state leaders, state behavioral health commissioners, as well as Medicaid directors and human services directors, is to convene the conversation. And then, as Secretary Wetzel challenged us, to own the outcomes. And in owning the outcomes, it's difficult because the outcomes are not great as you cross between these intercept points. And to listen, listening to law enforcement, listening and to the judiciary, listening to jail administrators has made a huge difference in how myself as the behavioral health commissioner, as well as our Medicaid director and the human services director, think and respond to opportunities to help locally. Medicaid is a huge potential source for filling gaps for targeted populations. If the data can show us who and where those populations are, Medicaid can do a lot. And even in states that aren't expansion states, mental health block grant and substance abuse prevention treatment block grant and state targeted responses, depending on the data, if we can do a good job screening for mental health addictions and criminogenic risk, then leaders at the state level can help you target and match different funding streams to those different groups of people.
Great. Thank you. Having been in the behavioral health field, many of us on this stage, for a minute or two, the landscape is just changing so rapidly at this point in time. And the financing mechanism, so addressing, Dr. Arkoosh, your statement about getting a little flexibility and having some gap filling, but the way in which money is flowing from the state to communities is really complex at this point in time. So I think I'm going to turn to you, Kieran, and that here you are sitting there at the local level. How do you navigate sort of with these complex financing streams, a managed care organization, to deliver outcomes that we care about in terms of public health and public safety?
Sure. So just by way of background a little bit, CareSource is a not-for-profit Medicaid managed care company with its history really in Ohio, in Dayton, Ohio. So Montgomery County keeps coming up. We're also in Montgomery County, but in Ohio. So there's a thread there. And 26 years ago, really, CareSource began as a very local, small health plan. And it's grown quite a bit, really, over the last 5 to 7 years. It's expanded. We're now in 5 states. But the heart of our business is in the Medicaid population, and the majority of that is in Ohio. So we have about 1.2 million Medicaid lives, right? So we've always known as an organization that just being an insurer isn't enough. And there's a real mission behind the movement of CareSource towards being more than insurance, but also being a resource for our members, and not only in healthcare. So as we look at our membership, we know there's high rates of individuals who are connected in one way or another to the criminal justice system. They might be moving through incarceration, and for those periods of time, they are not active on their Medicaid benefit, but we know that there are members on the front and the back end of that experience. There are also many, many more that are going through the community system, through probation and through parole and through the court system, right? So we come to bear with some to the question around finance. There are some things that we pay for in terms of health care. I think more importantly for this population, we understand that identification of their criminal justice involvement is truly an important factor in how we engage with that member, how we engage with resources and providers in the community. And that's a challenge. Traditionally, we do not know when our member goes through correctional settings. So we don't have any way to know if someone's entered a jail until recently, not whether they've entered the prison system, and much less so even the court system. So there's a big movement, and because the core of our work is happening in Ohio, we've had the opportunity, there's a lot of state leaders, I'm looking back at the Ohio table, that have been very committed to doing just that. And so we are an expansion state in Ohio, which obviously creates an environment where this population has a lot more access to Medicaid, where 4 or 5 years ago before expansion, that was not true. And so there's been a lot of work at the state level to ensure that there's pre-release Medicaid enrollment and linkage of individuals to managed care plans. And that's actually required in Ohio through the state plan. So Department of Medicaid has made that a requirement of all 5 providers. And that is really the foundation now for CareSource and other managed care to say, we now have identified our population coming out of state prison. We know that they're coming out with high rates of chronic conditions, mental health, substance use, and it's incumbent upon us. We have responsibility for these members and that transition and their life going forward. Obviously, healthcare is not the only answer when we talk about recidivism and reducing that, but it's certainly a big piece of the puzzle. And I would say from CareSource's perspective, it's how do we approach the coordination of that healthcare, but also what other resources can we bring to that population when we talk about employment, housing, and really to be successful, we need to be bigger than insurance, and we need to look, and we can talk a little bit more here, I think where we're going, on innovative ways to think beyond Medicaid as just the only source of financing to serve this population that we're already working with.
So let's pick up on that thread a little bit then, and that certainly within the Medicaid program, there are essential health benefits that are there that cover a variety of services. But we're talking typically about a population with pretty complex needs, and that their requirements for care don't always match the fee-for-service environment or even your managed care contracts well. How do you fill the gaps, and where do you look to fill the gaps, and what type of funding and services are you seeking resources for that make a difference in these individuals' desistance from crime and moving forward in their recovery?
Sure. So I come from the community system, so I've worked for many, many years on the not-for-profit level with community mental health. And so one of the changes and one of the things that we think a lot about at CareSource is how do we think, not like an insurance company, but as a partner in that community system. And so around reentry, the Department of Mental Health in Ohio put out a competitive bid for a reentry program called the Community Transition Program. And that's general fund money that works to fill, for lack of a better term, some of the gaps that individuals are facing returning from Ohio prisons. So individuals are eligible for this program if they have a substance use disorder and they receive treatment while incarcerated through recovery services with the Department of Corrections. And those individuals can voluntarily opt in before release to this community transition program. And again, most of them are coming out also with Medicaid, about 70 to 75%. But this community transition program allows for an increased or a broader set of services that are traditionally not Medicaid reimbursed. So through this program, we're serving about 3,000 individuals. And in addition to that 70% or more having a Medicaid benefit, they also now have access to things like housing. So through this benefit, we can pay for supportive housing, through sober living, and for some, depending on and they're all assessed prior to their release for their housing need. They can also get up to 4 months of a subsidy under a rapid rehousing model. So again, traditionally not a covered service under Medicaid, but through state partnership, really filling some of those gaps. In addition, employment can be paid for, transportation that's not medically required, which would be covered under Medicaid. This could be and is used by our local partnerships for all kinds of transportation, whether it be bus passes, it could be Uber rides. I mean, we're really allowing our local partners who are our AOD substance abuse providers around Ohio to be creative in how to use those funds. Individuals can also get assistance with paying for their state ID, birth certificate, and sort of the things they need when they re-enter, right? And so That program has been up and running now just over a year, but the real point of that is we know that this population has specific needs that are above and beyond what is able to be met by CareSource through the Medicaid benefit. And we really need to work in partnership with state departments to ensure that we're meeting those additional resource needs that these individuals have. And I think really importantly, the process by which they're re-entering. So one of the really great benefits we can provide today through the CTP program is InReach. We connect our members to AOD providers in their community where they're returning, but we can also pay those providers to go to prison before their release and do engagement, do assessment, and what we're finding is for those members who get an InReach from their community provider, the same person who will serve them when they return, they're 5 to 7 times more likely to show up in the community for those services. That's huge. This is a population that largely does not have a history of using health care, does not have a history of using community services, and we need to do a lot of work structurally to ensure that engagement's happening on the front end. That continues to expand. We're reaching about 30 to 35% of our returning population before release. We obviously want that much larger. The more we engage early, the better the community engagement is on the back end.
Wow. InReach, Uber drivers, IDs, housing. I mean, these are things that behavioral health providers don't traditionally think of putting in the package. We have 35 state directors of mental health, Director Zeller. This local provider is saying, I've got great ideas about gap-filling services that are required. What can the state do? What other ways can the state support those range of services that are associated with good outcomes?
Well, it's a great question. And again, Medicaid's been mentioned here a lot. And Medicaid, you've met one Medicaid state agency, you've met one, right? We're like ice cream. We're a whole bunch of different flavors, right? The good news about that, though, is that if we can get good identification at the point of service, let's use jails, if we can identify who has mental health needs through a common screen, who has addiction-related needs, and importantly, something we state commissioners are not very good at, and I'm sure the rest of the 34 of you out there would agree with me, we don't do criminogenic risk. And this is huge. We don't evaluate people for the typical reasons why they're high risk to recidivate, right? And it includes mental health, it includes addiction, it includes co-occurring, it includes whether they've been incarcerated before, and it includes homelessness. So if we can identify better at the beginning who has those high criminogenic risk needs and who's Medicaid can help with the homelessness risk, believe it or not. There's a wonderful Governors Association report called Housing is Healthcare, and it's very Medicaid driven. So we can maximize that Medicaid lane. Then another frustration we heard last week at the localities is that's all well and good. If people actually can be followed by community mental health, they have a 19% greater success rate at not coming back. So the big frustration locally in Michigan, and I know we're not alone in states, is that that's all well and good if you can actually get in the community mental health door, right? Because if you can get in the community mental health door, you can get access to the Medicaid streams, you can get access to the block grant streams, but I can't get my people into the community mental health that I know are going to be high levels of recidivating. So one of the other things state commissioners are doing more and more, and all aspects, all three branches of government are doing better together, is looking at the other funding streams. Substance Abuse and Mental Health Services Administration, SAMHSA, has been providing for a long time substance abuse and prevention treatment block grants. The criminal justice population has had increasing importance in the outcome SAMHSA is asking for states to provide in substance abuse and prevention and treatment block grant. Additionally, there's a mental health block grant that is intended to help follow those gaps or provide coverage It provides a very important safety net, especially in non-expansion states, related to getting those things that we know are the reason people with mental illness recidivate and addictions, but also everybody. Homelessness, prior history, mental health positive screen, addiction positive screen. So those are some of the tools that I know we can use. It's like we need to map the process first, own the outcomes, good and bad, and then get with our human services leaders, our Medicaid leaders, our local leaders, and then talk about which of those amazing amount of funding streams can be used to target which groups of people. But I want to put another plug in for screening. Can't do it unless I know who's screening positive for all of those things, and we get real in our conversation with our locals about what community mental health can do with their existing structure and funding streams and who falls outside of that. And then we can work with legislative partners and governors to try to come up with grants and funding streams.
Dr. Arkoosh, now your hat as county commissioner. You know about financing correction services around the country, representing 40 to 60% of your budget. $80 billion this year spent on it. Where do you look as a local official for the resources that might complement or augment or in the long term obviate the need for so many dollars going into corrections? What opportunities is there at the local level?
Well, I think you just heard from my two colleagues the importance of the sequential intercept mapping. I think the first step is to really understand what resources you have available to you, which we have spent quite a bit of time on in my county, and that's where we have discovered that we had funding through our behavioral health department, funding through our drug and alcohol department, that we could actually redeploy people and other services to help our colleagues on the criminal justice side. And we've been able to do that with great effect. We are using our program that helps to end homelessness on reentry and providing supportive housing. We can provide supportive housing services sometimes for as long as 18 months, depending upon the situation, with the way that we have our program structured at the county. So I think just understanding what you have and figuring out if you can make connections in a different way is extremely important. I also want to talk a little bit more, although, on the front end, too. I mentioned that we have a mobile crisis team, but I didn't mention that all of our municipal police departments undergo 3-day training, and it's been a program that's been in place for a long time. Our officers learn how to de-escalate. They're given a version of mental health first aid and some other tools to work with so that they walk into situations with a little bit of confidence that they can manage some of these, as we know, very difficult situations. But there's been a new aspect that we've been incorporating over the last couple of years, which is trauma-informed care. And in its simplest description, trauma-informed care is about asking a person what happened to them instead of asking them what's wrong with them. So what happened to you versus what's wrong with you. It's something I try to do with my teenagers every single day. I'm not always successful, but it is really an important shift in thinking, and we have found that that has been very useful for our officers, for our probation officers, as they try to thread the needle and figure out what does an individual need to keep them from recidivating, what can we do to help someone from ending up in the criminal justice system in the first place. The third aspect is our treatment courts, which I think just about everyone here has referenced today. We have an incredibly effective drug treatment court, behavioral health court, veterans court, and we are using those in the most maximum possible way that we can. And that's another place where funding and more resources is very useful. But another area where we're now co-locating individuals from our behavioral health department and our drug and alcohol department. So actually shifting staff from one place to another to maximize our resources. We are an expansion state, and I can't tell you how critically important that has been, particularly in our fight on the opioid epidemic, but I know many states are not, and still almost half are not. And so again, I think that this work of figuring out what you have and where you can redeploy is more important than ever in those states.
So Slight shifting gears a bit, but the opioid epidemic has come up repeatedly and will in our conversations, and it's a pressing crisis on our landscape at this point in time. Kieran, what strategies, and we've talked a little bit about some of the ways in which we understand how people with mental illness move through systems of care, but what strategies have you employed and found helpful in addressing substance use disorders in the criminal justice population, and in particular the opioid crisis?
Sure. So on a couple different levels, I mean, one is that we do see the real importance of local partnership. So Montgomery County, Dayton, Ohio, if you've read Dreamland or you've watched the news, oftentimes Dayton, Ohio is seen in some ways as maybe the epicenter of what's happening with the opiate epidemic. And so in response to that, there's really a public health response. And CareSource is very engaged locally. And so what that means is what we're doing in terms on a local level to build a model is to really work, for example, with police to help them better understand and engage with what is reimbursable by Medicaid. So currently in Dayton, Ohio, the Dayton police employ, and when I say employ, they have a volunteer peer recovery support specialist who works with them and an officer who sees individuals who have overdosed within 48 hours after their overdose to try to engage them in treatment. Well, one of the barriers that they face is truly understanding what is the front door to treatment, what is the resources that may be available. And so I think there's a model here for how Medicaid managed care needs to partner with police and to work with communities to ensure that resources are made available and to bear in this crisis. With that said, on the macro level, a place like CareSource and many managed care companies are trying to do their part to ensure that the providers that we have in the community have visibility to how they're prescribing. And so one of the really effective ways that CareSource has, I think in the last year, reduced opiate prescriptions by over 30% of our providers is to give them information, a dashboard, a letter that says, Dr. Smith, here's how you're prescribing compared to the other 10 doctors in this area. Information's important. We keep talking about data. And it has to happen at a scalable level, and it also has to happen at a local level with really engaging. And I know this isn't exactly the question, but I wanted to go back to a point that coming from the behavioral health side and then becoming an attorney, I often saw that, especially in treatment courts, that criminal justice systems were looking to behavioral health for answers in a lot of cases. Here's a system that is, they don't see themselves as behavioral health professionals, although I would say that many criminal justice folks are much more specialists than some people in the behavioral health field. But here's I think, the interesting thing, and I know Ed Latessa is, if he's not in the room, I know he's speaking later today, so I'm going to give a plug. Criminogenic risk assessment, why it's so important in this conversation is just linking people to substance use disorder treatment and mental health treatment does not necessarily lead to lower recidivism. What does? What do we know? It's the right cognitive behavioral therapy interventions around risk assessment. And the challenge there is not only how do you allow that data to flow, what is somebody's risk score, but how do you get the community system to understand how to implement those interventions? I would say the criminal justice system is way further ahead in this respect. Probation officers, corrections officers know how to do CBT interventions around risk assessment and how to implement those interventions. The community may know it in some respects. Those agencies that work directly with treatment courts, I think, have gotten pretty good at it. But I don't think that generally when someone walks through the door that community behavioral health does a great job of understanding the complex needs of populations that have gone through the criminal justice system. And even if they know what their risk assessment score is, I'm not sure that they yet really truly understand how to integrate that into the rest of their treatment. And that's really important. And I think it's a place where behavioral health has a lot to learn from criminal justice. And as these partnerships form, it's improved. But we need better systems of communicating that information across behavioral health and criminal justice.
So I just want to put a mark down. November 2017, we got 3 behavioral health experts talking about criminogenic risk and need. That would not have happened 5 years ago. And so I think as a field, we need to sort of be aware of each of us moving towards the culture that we work with to better understand, appreciate sort of the terminology and threats and opportunities that exist within those. So let's make a note of that. I would also, just sort of off script a little bit, want to return to information sharing as a conundrum, and that, you know, I'm going to look at you, Director Zeller, because we have federal laws with HIPAA and CFR 42, but we have state laws also that are pretty significant in governing the way information gets exchanged around behavioral disorders. It's a source of huge frustration for law enforcement, our criminal justice partners, our families. What can you do? What can a state do to address myth and reality around information sharing?
Yeah, well, this could be a whole session all by itself, right? So how many jail administrators say, you know, if community mental health could just exchange information about medications, right, immediately, or exchange information about who the case manager is immediately, this would help. So there is a lot, this is where a lot of the burden, I think, does fall on state leaders to dig down really deeply and ask the question about owning the accountability for the outcomes beyond ourselves, and then looking and targeting where information flow has hindered those positive outcomes. We've done a lot of this very difficult work in Michigan, and we've attacked successfully in a bipartisan way, correcting some of the laws that provided even greater restriction on our mental health information flow. So that's the good news. The good news is we got some laws changed. We have a universal behavioral health consent form for every public dollar that goes anywhere related to behavioral health. There's a uniform consent to treatment form. The challenging news is my own public behavioral health system is the least excited about implementing that form. So it's very interesting. So we need both I think we need a community-led strategy and a state-led strategy that is rowing in the same boat at exactly the same speed and together. And if one gets too far ahead, and in this case, the state law and the state consent form got a little bit ahead of the community behavioral health, my jails are super excited. My physical health group is super excited in using the form very well and advancing it. But on the community behavioral health side, there's fear driven by stigma. So I think the challenge with health information exchange is both in terms of laws and in terms of using the tools, but more importantly, making sure the cultural move that you don't get ahead of these different groups, whether it be addictions, world and that stigma, mental health and stigma, because the tools and the technology is the easy part. The laws in some way are the easy part. It's the cultural change that has been our bugaboo in Michigan. So we're still working on it, but the good news is there's all kinds of tools out there, and there is an appetite now, like there hasn't been before, for changing that and getting information moving that you need to get people identified and then connected to the right treatment at the right time.
Thank you. As we are winding down, Dr. Arkoosh, I'm going to ask you to put on your Johns Hopkins hat for a moment here. The panel before said, we've got to focus on prevention. We got to go upstream. The chief in Montgomery County said, let's invest in our middle schools. All of this sort of rings true with a public health approach and a public health framework. Can you tell us how you might apply that framework in addressing the crises that we're talking about?
Yeah, I really agree strongly with that. I think that there's so much stigma around behavioral health issues in this country, and it starts at our earliest stages. And so we know that our teachers could probably tell us by first or second grade in some cases, children that are struggling. They may not know why, but they know that those kids are already off to a difficult start. So I think one of the people that I don't believe is in the room here today, but that we need to bring into our fold here is our departments of education. And I suspect that not only do a huge number of people in our correctional facilities have behavioral health issues, but I think many of them probably also have learning differences, and that has been at the root of their difficulty in school and not being able to graduate with skills to enable them to get a good job. So somehow I would love us to figure out how we could do a better job of screening for learning differences and food insecurity and domestic violence at home and some of these other issues that we know, adverse childhood experiences that we know will absolutely set an individual on a path that whose very likely conclusion is a correctional facility. And if we could start doing that earlier, I think we could make a lot of help. We're very fortunate in Pennsylvania to have a very strong County Commissioners Association of Pennsylvania. Brenda Prynek is sitting over there in the teal jacket, and she's a host of wealth of information. But one of the things that we've done as a state is come together with the Behavioral Health Task Force with the sole goal of trying to figure out how we could, in a very diverse state, reduce the number of people that are incarcerated. And a lot of this preventive work was highlighted, not only with children, but veterans who are returning from service. Wouldn't it be great if we had a really robust community welcoming system for our veterans so that we knew what they were coming back to and we could give them the supports that they needed to reintegrate? There's so many places where I think we could do prevention. We're so busy with our finger in the dike trying to sort of, so it really is a bit of a both and a chicken and an egg at the same time. With finite resources, where do we put them? But I feel very strongly that we have to take some of those resources and put them into prevention, or we are never going to solve this problem.
Thank you. And it's not an easy sell. Because the outcomes from that investment are down the road. So we really need advocates like yourself to push that so we can get all of what we want in the future. So here we sit at the end of our short time here. What I've heard is sort of iterated many of the themes that if you don't know the people that you're working with, if you haven't screened, assessed, and identified their needs, it's really difficult to design effective intervention strategies that assist them moving forward in our community. Further, that if you don't give them interventions that are associated with the outcomes that you care about, interventions that work, and finance those in a variety of ways, we too are not going to get the outcomes that we need. And then lastly, I think all three of the panelists here are boundary spanners, know each system well, and can really help lead in what we hope will be the next day of collaboration, where as systems we come together, sharing ideas, and ultimately getting the public health and safety outcomes that we care about. Thank you very much, and look forward to the rest of the day. Please join myself in thanking the panel.